on how can we in fact introduce biosimilars in common life, in our common clinical life, okay? So as we have heard, we have biosimilars of Infliximab, specifically the CT P13, available for a few years now. Okay, so we have it available since 2014, more or less. So what we've done, as you can imagine, was initially to use it as first line. Okay, first line for gastroenterologists makes sense because Infliximab is clearly a first line treatment for colitis, for gut inflammatory disease, but it is not a first-line drug in rheumatology. Okay, in most countries it is not a first line for any indication. Okay, so that created a situation where we had in fact an uptake of this biosimilar for first-line users, which was relatively low in rheumatology. Okay, a few patients were introduced, and so what we thought here at the level of our department was that if you would like to have in fact a significant uptake of this biosimilar, that was something that we were attracted by because of the cost, we should make a systematic switch. But it's a systematic switch made in our hands and led by our department, by the clinicians and the physicians. Yeah, everybody that is taking care of the patients, and the patients of course also. So everybody together was engaged in the process. And of course there was a goal which would be to reduce the price, to lower the cost. And one thing that we can discuss over these 2 days is what to do with that economical advantage. You have mentioned that individually speaking, for each one of us, we can have a direct advantage if we pay somehow the drug, okay? If we co-pay with an insurance company or if we pay by ourselves as a patient, we have a direct advantage. But if we are working with a National Health Service or any kind of institution, there is an economic advantage that might be lost inside the institution. You see what I mean? So we made all the efforts to use biosimilars, but then the economical advantage goes to other place. We don't know exactly where. It might go back to the Ministry of Health. It might go to the colleague on the other corner that is taking care of heart patients, for instance, and not exactly to help and to facilitate the life of rheumatic patients or gastroenterology patients or hematology patients. Okay, so that's one of the things that we can debate over these 2 years. But my goal in this presentation is go directly to the facts, that is how to switch and how things are going with switch. Okay. So I will just briefly address the North Switch you have heard about. And this database, the DANBU, which is the national registry at Denmark, okay? As you've heard, they switched everybody, okay? In a mandatory way, which is different from other countries. It was a mandatory way. So it's a lot of patients that are there. The DANBU is the rheumatic registry. So it is uptaking data from rheumatic patients, okay? And then I will tell you about our real-life experience of switching. So this is the North Switch. I won't take any time with it because we have discussed this a lot. You know that patients were stable on Infliximab Remicade. They were randomized to 2 arms. One was taking Remicade and the other one was taking the biosimilar CT P13. What was in stake was the amount of patients that would get worse in one arm versus the other arm. That was the discussion, okay, all about that. And there were definitions of worsening that make a lot of sense for rheumatologists. I won't go into detail because this is typically the stuff that rheumatologists are very aware of, but other specialties naturally are not aware of. So these are scores that we use a little bit like the Crohn's disease or the ulcerative colitis score. So for hematologists, I guess that these kind of scores are not part of their daily activities, and I won't get into detail. But we could think on other diseases, hematological diseases, where we would have also scores, and we could do more or less the same, okay? So the point here is that just looking at the overall data, okay, there is a variability of disease activity that goes over the time in both arms. And we are used to this in Crohn's disease, we are used to this in rheumatoid arthritis, ankylosing spondylitis, even psoriasis. This inflammatory disease goes like this, okay? Particularly for those of you that are not rheumatologists, if you like art, I would like to get your memory into a man that was very representative of a style of painting, which was the Impressionist painting. I know that rheumatologists know this, the others I'm not sure, but Renoir, okay, Renoir was one of these great artists representing the Impressionist form of art. He had rheumatoid arthritis, okay? Renoir started rheumatoid arthritis around 40s, okay? He died around his 70s. He died painting all the time. So he painted up to his last day of life, okay? He was completely crippled by rheumatoid arthritis. Wheelchair bound, completely dependent on his family. He painted with the paintbrush like this in his hand, with ropes tying, okay, the paintbrush, and he painted seated like that, just using a little bit of the elbow, a little bit of his shoulder, like this. And he was painting all his life like this. Most of his great paintings were painted like that, in a time that there was no treatment for rheumatoid arthritis. But what I want to tell you is that his son was very well known also. He was called the Jean Renoir. You might have heard Jean Renoir. He died recently, his son. He was a famous movie. Well, he made films, and he organized also companies that were going around this film. So he was famous in Hollywood, okay? Jean Renoir wrote a book about his father, okay? If you read that book, you read the story of this form of art, but essentially you take the feeling of a patient with rheumatoid arthritis, and you see this undulating nature of the disease, okay? All these inflammatory diseases goes like this. And if you don't have a drug to treat you, you go like this here, with a lot of pain and deformity. If you have good drugs to treat you, you go like this, with low pain and good function, but you go like this, okay? And this is true for counting the joints. This is true to see the blood test like ESR or CRP, the inflammatory markers. And this is more or less what you see with inflammatory gut disease. It's more or less what you see with psoriasis, etc., 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 okay? So that's why when you look at this kind of graphs, you see this undulation, okay? And that's why when you compare at the same time patients that are taking a biosimilar with those that are with the originator, you can have individual changes, differences, I mean, okay? And if you're taking an originator and then you start to be treated with the biosimilar, what can happen is that, in fact, if you have one of those undulations in the bad sense, in the meaning that you're getting worse because you would be getting worse anyway, you'll get the feeling that I'm getting worse because I switched to the biosimilar, you know? So this is a problem that you have to face in these diseases, okay? This and our mind also, because we think, well, I'm going to switch to a different drug. This is called a biosimilar, but this is exactly the same. That has happened also with generics, of course. So this is just to recall you of this undulation pattern of disease. But the point of the trial was that, in fact, both arms were equal regarding efficacy and safety. Okay, that is the main message. And using exactly that main message, we decided to switch in a very systematic way, although always discussing with our patients what we were doing. This type of results, supported also by safety information and also immunogenicity information, it's not just that it is equally adequate to treat this disease, but it is also equally safe, safe from an immunogenic point of view. A point that is important to be made here is that this trial does not give information about the switch to other biosimilars of Infliximab, okay? Neither back to the originator. So this is not saying that all the biosimilars of Infliximab Remicade are okay. We're not sure. So we know that switching to this one works well, but we don't know, in fact, from this trial, that switching back to the originator is okay. Probably it is, but we don't know. So it is not also a proof of concept of switching between any originator and its biosimilar, okay? But it's something that was useful, historically speaking, to change the mind of the people like me that were treating patients, okay? So DAMBU, this is just, you don't have to look at the details. This is just to highlight that there were a lot of patients, 800 patients, 400 rheumatoid arthritis, almost 300 spondyloarthritis patients, and more than 100 psoriatic arthritis patients. This was real-life experience comparing disease activity 3 months pre-switch, and this is important because they were looking at the past, then to the present, the moment when they did the switch, and then 3 months after, just to show that there was stability, because in large numbers you can show stability. For an individual person you got this, but you have large numbers, then you lose this kind of wave-like behavior, because the patients will enter into an equilibrium of disease activity. So pre-switch, time of the switch, 3 months after switch, it was all equal in terms of disease activity, okay? So this was a very important piece of data because of a lot of patients were included here. What went slightly different between the biosimilar and the originator? This is linked to what we were saying. This is linked with the expectations, okay? So remember, this is open label. This is not a trial, okay? So people knew what were they doing, okay? And you see here a comparison between CT P13, this is gray, CT P13, and this is Infliximab originator, but this is historical controls. So the database captured patients on Infliximab originator before, okay? So you see here historical controls. And you see a slight difference in the survival, meaning the retention rate, the number of patients that were kept on the drug. A slight difference, this is 3.4%. A very slight difference, and this can be regarded as a good example, probably, of a nocebo effect. So it's the expectation that people have about their own disease, okay? And I had plenty of this nocebo effect in my daily life when I started to use the switch to CT P13. So what we've done, so as I told you, Infliximab, and I will allude to that tomorrow in another presentation, is not a first-line treatment for rheumatic patients, at least in our country, for several years. Okay, for several years. So what we had in our hands was a very special population of around 60 patients that were very well controlled for many years on Infliximab. So some of them were rheumatoid arthritis, others spondyloarthritis, others psoriatic arthritis patients, but they were very stable, all of them. Okay. Very stable. Our measurement of what we were seeing was based on efficacy measure that we use, again scores that you use in rheumatology, very similar to the ones that we applied in the Northwich or in the DAMBU database, okay? And we also define disease worsening. So what is disease worsening for a specific patient? And we've made a cost analysis. So we were very motivated to understand if indeed we were making all this effort of switching, explaining to all patients individually. We were speaking to every patient. It's not an informed consent. We were not asking for them to ask. But you know that ethically speaking, you should discuss with the patient if you are doing something different, okay? Ethically speaking, it's not because of laws, it's just because of ethics, okay? So we did discuss with all patients. And just to have a view of these real life patients, so their mean age was, the median age was 53, disease duration 17 years, so long-term patients. Most of them had previous biologics, 4, medium number of previous biologics, 4. So these were patients that had experienced other biologics. And on Infliximab, they were for 8 years. So very stable patients treated for 8 years. And then we followed up. This data regards this follow-up for 9 months. Okay, of course, we now have more follow-up of these patients. Okay, what is the point? The point is that after 9 months of follow-up, the variation in ESR was 0. The variation in CRP was almost 0 also. Patient global and physician global was more or less 0. Of course, you're speaking about relatively big numbers, 60%, of course. If you look at each individual person, you would have fluctuations. But the point here is that the variation from baseline is basically 0. Of course, you see a little bit of variation of the scores, because the scores have many individual data, and this was separated now by RA patients, rheumatoid patients, psoriatic patients, and spondyloarthritis patients. But the point is that the so-called wave of disease activity more or less is stable. So patients were okay. The other point that we addressed here was also the patients that had to stop. We had 4 patients, in 60 patients, 4 stopped. Let us just have a look at them, just to understand how real life is, okay? Because it wouldn't be real life if I would tell you that after 9 months, no patients would have stopped. That would be very strange, okay? Because in real life, we have patients that stop these treatments in chronic disease, particularly in rheumatic patients. We have to separate here a little bit gastroenterology from rheumatology. Where gastroenterology, because Infliximab is in fact the leading drug, we all know that gastroenterologists make a huge effort in decreasing the interval between the dosing and also the dose that are increased in order to push patients into a very good control of the disease and keep Infliximab. Rheumatology is different because we have a lot of drugs approval, and so we don't insist. We switch very, very quick, and you'll see this. These are switches that are very quick. You could argue in your daily life that you wouldn't switch. Okay? In this same room, we have a meeting every morning. Every Tuesday morning in this same room, by coincidence. Okay? Where we meet all the group. We are around 40. So we are 18 consultants and 12 trainees, 12 registrars or interns, or it depends on the country. You name the trainees in a different way from each country. So what we do here is exactly to decide in a group, as a group, if we start a new treatment, we switch, etc. So these decisions were taken together. Okay. So one of the patients, after a median follow-up of 261 days, the 4 patients after a mean follow-up of 261 days had to stop. So 3 had a disease worsening. We'll see what this means. One patient had a minor adverse event. He had lip edema. Okay? So let us look at the patient number 1, a male, 48 years old, with psoriatic arthritis, disease duration 18 years. He was not on concomitant methotrexate, which is relevant in the field of rheumatology and also in gastro because it decreases the antibodies against the drug. And for him, Infliximab was the first drug, so he was never exposed to other drugs before that. So Infliximab originated for 14 years in this case, okay? But before the switch, don't forget that we are rheumatologists, so we are counting joints, but we didn't take care of a fact. He was having an aggravation and a worsening of the skin manifestations of psoriasis, okay? This was by reviewing the chart. This was occurring before the switch, but we didn't take that into attention. Okay, after 1 month on CT P13, in fact, he was not feeling well, okay? And because of that, when you are asked, how are you feeling last week regarding your disease? If you are full of psoriasis, you'll say, I'm worse, of course, okay? So he said that, okay? So from 40 to 100, he said 80. Okay, but the rest was okay. But this increased let's say his overall clinical picture was changed. And so we decided here in this room that this patient should be switched to ustekinumab. Okay, ustekinumab, that at least some of you are familiar with this drug, that works well in skin, particularly in skin, also in joints, but particularly in skin. Okay, so we decided this, having noted, of course, that probably this patient shouldn't have been switched to the biosimilar because he was needed probably to be switched to another mechanism of action. Okay, but in fact he went in this sense. Okay, patient 2, 59 years old, spondyloarthritis. This is duration 12 years. This guy is on methotrexate, concomitant methotrexate, and again Infliximab was the first biologic. Okay, for 11 years. Okay, but since the first administration, the patient reported no treatment effect. So he was great, he was feeling great, and then when he started to use CT P13, he told everybody, no, I'm not okay with this. Okay, what were the facts? Okay, so ESR 8, 9, 17, 10, CRP 0.7, 003, 0.26, 0.5. So normal in our lab is 0.5, okay? The global health from his perspective was worse, okay? But the physician perspective was more or less the same. So in fact, the counting of the score was a little bit worse, but was comparable with the others, okay? What did we do? So we decided that this patient, because of feeling worse, without any objective aspect that we could value, was needing a switch. We decided to switch him, and we switched. This is debatable. Probably in most parts of the world we wouldn't have done that, but we did this. That's the fact. Okay, we decided this switch. Okay. Then the third patient, 75 years old, rheumatoid arthritis. Disease duration 24 years. Concomitant methotrexate. Infliximab was the first biologic. Don't forget that we're speaking about a very special population that stayed very well over the years with infliximab. Again, 11 years. Okay. Again, the same pattern. Since the first administration, the patient reported no treatment effect. No treatment effect at all. What are the facts here? So ESR, well, it raised a little bit. CRP is comparable, okay? Counting joints, etc., 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 gave rise to a little bit of an increase, okay? Because essentially of this component, the patient global, that increased a lot to 70, okay? So what was decided? This is also very debatable. So the patient went back to the infliximab originator, okay? And he said, well, so these two last patients were just pressing since the beginning that they were not okay. Okay. This is the fourth patient that we stopped, spondyloarthritis patient, 30 years old. Infliximab was the first biologic monotherapy. Infliximab originated for 7 years. 3 perfusions of CT P13, he had lipedema. Okay? So in these conditions, we switch always. Okay? I believe that in gastro, you would not do anything. Probably you'll try to give corticoids and try not to lose this patient for infliximab. But in this condition, we do this. Of course, if you review our own experience or your own experience on the use of infliximab, this is something that can happen at all times. So you can have minor reactions to a drug even years after you start the drug. Okay, so this is nothing special for us. This is something that happens and we are not distressed with that. So the major conclusion about our experience was essentially the point regarding economical costs. So here you see in blue the uptake of CT per P13. So this is the increase of the vials that we use, okay? And here you see the decrease of the vials of the originator, okay? we didn't switch everybody because kids were not switched, so we had a few off-label kids on Infliximab. We had also a lot of off-label Infliximab use for uveitis, etc., etc. We didn't switch off-label. This was because of legal aspects, because we would have to ask permission to the ethics commission, because you see it's a new off-label. So it's a new drug, you make the switch, and then you have to address the ethics commission and also the pharmacology commission to ask permission for the use of off-label biosimilar on that indication. So we didn't do that. That's the reason why we still have a few patients on Remicade originator. But with this, we significantly reduced the cost, treating the same amount of patients, okay? And this was around 26% reduction. The major point for us is that after we started to use biologics here, paid by the government, not in clinical trials, since 98. So 98 means 20 years. And during 20 years, every year, we had increased the costs of treatment in our department every year. Okay? So we had an agreement that we should not increase more than 4% a year. So that was our deal. So they had accepted that this was something that would happen every year. And so for the first time, and just using this, for the first time, we had a decrease in the cost of treatment. Not of 4%, of course, but we, for the first time, decreased the cost of treatment in our department. So this was something that was very stimulating for everybody. So what was the conclusion of this local experience? The switch in routine care of a group of RA spondyloarthritis and psoriatic arthritis patients from Infliximab originated to CT P13 did not affect efficacy and safety. No changes of the different disease activity scores were observed during follow-up, okay? Particularly CRP and the ESR remained stable. The two patients that stopped CT P13 due to joint symptoms, because I recall you that one patient got worse from psoriasis, and this psoriasis crisis was starting before the switch, okay? So the two that indeed got worse because they were more symptomatic from the joints point of view, had only changes in patient-reported outcomes, meaning the physician, global, etc., suggesting a nocebo effect of the switch, and not exactly any kind of organic problem that was going with them. Okay? So the point that I would like to make, but I'm not going to make because I'm going to finish here with a set of a few more slides that I'm not going to show, is that in these patients we also assessed immunogenicity. Okay? As you can imagine, these fluctuations that go over the time regarding clinical symptoms also happen in our bodies regarding antibodies, okay, raised to these large molecules, because all antibodies that we introduce in our body are highly immunogenic, okay, including golimumab. Golimumab is the least immunogenic of the molecules, but still is immunogenic because it has the structure of a monoclonal antibody. As you know, the only treatments that we give that have low immunogenicity are etanercept and abatacept, fusion proteins, because if you use monoclonal antibodies, you get this kind of antibodies. And just to be brief, there are two types of antibodies. Those that are very brief and go like that and don't take away from our body the drug, okay? They appear and disappear, no major consequence, okay? And those that are in fact neutralizing and capture the antibody, the drug in this case, and they are internalized by Fc gamma receptors, and we destroy them. Okay, and the antibody levels will go low, and then we might have consequence in terms of efficacy. So what we've done was to collect blood in baseline. Okay, this is the true point where the levels are lower. Levels of the antibody against the drug and levels of the drug are lower, okay? And then we collect it in the same point later on after the switch. So that was what we've done. And to make a long story short, what we got was a little bit of fluctuations of antibodies, of measuring of drugs. This would be something that if you want tomorrow we can discuss, but for today we'll pass. a little bit of fluctuations, okay? But the conclusion was that patients who had received originator infliximab and switched to CT P13 had minor changes in serum infliximab, okay, and in antibody against the drug levels, okay, but the observed changes were not associated with higher disease activity and did not lead to withdrawal of infliximab therapy. Importantly, the patients who stopped infliximab therapy, so the patients that stopped infliximab therapy, those that I showed to you, did not have a change in serum infliximab or anti-drug antibodies, you see? So those patients that I've spoke about, that we had to stop, in fact, those patients didn't have any change in infliximab levels or antibody levels, okay? So one point that comes from here is exactly regarding what Dambio told us about looking at the past first of the patients. First look at the activity over last month, then look at last activity, and then look at the activity in the following month with the biosimilar. And the same should be done if you want to be completely sure what we're doing. We should take blood in several time points before switching, and then take blood in several time points after switching. And then if you want to compare adequately, we should compare it like that because of the fluctuations that we have, okay? So before going to lunch, so the conclusions of this presentation are, so regarding infliximab, Northwich and Dambio support the switch to CT P13. It's something that we have now very solid. Our own data show positive experience of switching to CT P13. And the final comment was that I was already making. Savings obtained with the use of biosimilars should be made evident to rheumatic patients through improving care conditions and to rheumatologists by transmitting the evolution of costs with biologics. I'm speaking about rheumatology, but this would be valid, of course, for other areas. So it's very important to engage public money into a system that will get secondary benefits to our patients and also to our department to give better conditions to patients, etc., etc., etc. This is something that we can think on and discuss in the following session. So